Part B of Chapter 8, Learning about the Joints. So we're going to take a few selected synovial joints and learn more detail about each one. Synovial joints are incredibly diverse. They all have general features, but some have unique structural features, abilities, as well as weaknesses. Our five main synovial joints are the jaw joint, or the temporomandibular joint, shoulder joint, elbow joint, hip joint, and knee joint. We'll start with the temporomandibular joint. The jaw joint is a modified hinge joint. The mandibular condyle articulates with the temporal bone. The posterior temporal bone forms the mandibular fossa, while the anterior portion forms the articular tubercle. The articular capsule thickens into a strong lateral ligament. There are two types of movement in the temporomandibular joint. You have the hinge, which gives us depression and elevation of the mandible, and then you have the gliding portion, which is side to side, otherwise known as lateral excursion, grinding of the teeth. Most easily dislocated joint in the body is this temporomandibular joint, or TMJ. Taking a closer look at the TMJ, we have our articular capsule, the ramus of the mandible, the lateral ligament. Of course, we have our external acoustic meatus, or ear canal, the mandibular fossa, the articular tubercle, the zygomatic process, and the infratemporal fossa. Getting in a little bit closer, we can see more details here. Here we have the synovial membranes, the condylar process of the mandible, the ramus of the mandible, the inferior joint cavity, the superior joint cavity, anterior tubercle anteriorly, the articular disc, mandibular fossa, and articular capsule. The lateral excursion, or lateral side-to-side movements of the mandible, is illustrated in this picture. Clinically, the dislocation of the TMJ is the most common because the socket of the joint is very shallow. It almost always dislocates anteriorly, which causes the mouth to remain open. To realign, the physician must push the mandible back into place. Symptoms of a dislocated TMJ include ear and face pain, tender muscles, popping sounds when opening the mouth, and joint stiffness. Usually this is caused by grinding of the teeth, but can also be due to jaw trauma or poor occlusion of the teeth. The treatment for grinding of the teeth may include a bite plate, and relaxing the jaw muscles will help. Moving on to the shoulder joint, or the glenohumeral joint, this is the most freely movable joint in the body. Its stability is sacrificed for this freedom of movement. It is considered a ball and socket joint. It is very large. Hemispherical head of the humerus fits into a rather small, shallow glenoid cavity of the scapula. It's like putting a golf ball on a tee. The articular capsule of the glenohumeral joint encloses the cavity and is also thin and loose, and this contributes to the freedom of movement, but the instability as well. Here's a picture of our shoulder joint. Orienting you, this is a frontal section through the right shoulder joint. This is the acromion process of the scapula, the head of the humerus, and the glenoid cavity or glenoid fossa. So you see that it's not much of a socket, very shallow. Here is a cadaver photo of the shoulder joint. Again, this is a frontal cut. The synovial cavity within the joint, the articular cartilage on both the glenoid cavity and the humeral head. The glenoid labrum is a fibrocartilaginous rim around the glenoid cavity. This helps to add depth to that shallow glenoid cavity. The cavity still holds only 1/3 of the head of the humerus, even with the glenoid labrum. Additionally, in the shoulder joint, we have reinforcing ligaments, primarily on the anterior aspects of the shoulder joint. The coracohumeral ligament is named from where it comes from and where it goes to, the coracoid process to the humerus, and it helps support the weight of the upper limb. We have 3 glenohumeral ligaments, which strengthen the anterior capsule, but are a rather weak support. Here we have your coracoacromial ligament, the articular capsule reinforced by the glenohumeral ligaments, the coracohumeral ligament, and this is the anterior view of the right shoulder joint capsule. Here is a lateral view of the socket of the right shoulder joint, where we can see clearly the labrum, giving a little bit of depth to that ball and socket joint, the glenohumeral ligaments here as well. Reinforcing muscle tendons contribute the most to the joint stability of the glenohumeral joint. The tendon of the long head of the biceps brachii muscle is the super stabilizer. It travels through the intertubercular sulcus and secures the humerus to the glenoid cavity. We have 4 rotator cuff tendons that encircle the shoulder joint. Those muscles are subscapularis, supraspinatus, infraspinatus, and teres minor. Here's a posterior view of an open right shoulder joint. And here we have the rotator cuff muscles that are cut away, and the glenoid cavity of the scapula, the glenoid labrum, the head of the humerus, and the capsule of the shoulder joint, which is opened up. Clinically, we see shoulder dislocations. They're quite common due to injuries from mobility, overmobility of the shoulder. The structures reinforcing this joint are the weakest anteriorly and inferiorly. So the head of the humerus, when it dislocates forward and down. The glenoid cavity provides poor support when the humerus is rotated laterally and abducted. For example, when a football player uses his arm to tackle an opponent, it is very vulnerable. Blows to the top and back of the shoulder can also cause dislocations.
The rotator cuff is a term used to describe the group of muscles and tendons that stabilize and reinforce the glenohumeral joint and assist with the angular and rotational movement. There are 9 muscles that cross the shoulder joint and act on the humerus. Of these 9 muscles, only 3, the latissimus dorsi, the the pectoralis major and the deltoid muscles are considered prime movers of the shoulder joint. The other 6 muscles play a synergistic role in movement, but their primary role is to stabilize the shoulder joint. 4 of these, the supraspinatus, infraspinatus, teres minor, and the subscapularis, are grouped as the rotator cuff muscles and are discussed separately. The remaining 2 muscles are the teres major and the coracobrachialis. The muscle origins and insertions in relation to the glenohumeral joint are best introduced as anterior and posterior muscles that originate off of the scapula, and anterior and The anterior scapular muscles that cross the glenohumeral joint are the coracobrachialis, the biceps brachii, and the deltoid. The coracobrachialis muscle originates on the coracoid process of the scapula and inserts on the medial surface of the humeral shaft. The biceps brachii muscle has 2 parts, a long head and a short head. The short head originates on the coracoid process of the scapula, while the long head originates on the supraglenoid tubercle of the glenoid cavity. The 2 heads of the biceps come together distally and insert on the radial tuberosity, just distal to the elbow joint. The deltoid muscle is composed of 3 distinct sets of fibers: the anterior fibers, which originate from the anterior border and lateral third of the clavicle, the middle fibers, which originate on the lateral margin and acromion of the scapula, and the posterior fibers, which originate on the posterior border of the spine of the scapula. All fibers converge to insert at the deltoid tuberosity of the humerus. The posterior scapular muscle that crosses the glenohumeral joint is the teres major muscle. The teres major muscle originates on the inferior angle of the scapula and inserts on the medial edge of the intertubercular sulcus of the humerus.
The elbow joint. The humerus articulates with the radius and the ulna. It is a hinge joint that is formed primarily from the trochlear notch of the ulna, articulating with the trochlea of the humerus. It allows for flexion and extension only. The annular ligament is the ligament that surrounds the head of the radius. And there are 2 capsular ligaments that restrict movement side to side: the ulnar collateral ligament and the radial collateral ligament.
The forearm flexors consist of the brachialis, the brachioradialis, and the biceps brachii. The brachialis muscle originates on the front distal half of the humerus and inserts on the coronoid process of the ulna. The brachioradialis originates on the lateral supracondylar ridge of the humerus and inserts on the base of the styloid process of the radius. The biceps brachii has 2 parts, a long head and a short head. The short head originates on the coracoid process of the scapula, while the long head originates on the supraglenoid tubercle of the scapula. The 2 heads of the biceps come together distally to insert on the radial tuberosity, just distal to the elbow joint.
Here is a close-up of the elbow joint. We have the humerus coming down. This is the trochlea. And then, of course, we have the ulna, the trochlea notch in the ulna. And this allows for flexion and extension. Again, the elbow joint, we have the humerus, the radius and the ulna. And here's the radial collateral ligament that we can see laterally. The annular ligament goes around the head of the radius. Here's a cadaver photo of the medial view of the right elbow, and here we can see the ulnar collateral ligament. Medial epicondyle of the humerus and the articular capsule. The annular ligament is in this section. There is a nice view of the elbow.
The elbow joint is a hinge joint. Therefore, the muscles that act on this joint are limited to flexion and extension of the forearm at the humero-ulnar joint, while the forearm itself is capable of pronation and supination.
The hip joint, also known as the coxal joint. This is a ball and socket joint. It's very large. The spherical head of the femur articulates with the deep cup-shaped acetabulum. The hip joint has very good range of motion, but is limited by the deep socket. There is a labrum on the acetabulum, similar to the glenoid. And this rim of fibrocartilage enhances the depth of the socket. Dislocations of the hip are incredibly rare. Here we have the hip joint. This is a frontal section through the right hip, and we have the femoral head coming in here, the acetabulum, and here is the glenoid labrum, creating more depth to the ball and socket joint. Of course, the articular or hyaline cartilage along the joint surface. This is the ligament of the head of the femur, also known as the ligamentum teres. The synovial cavity is here, the articular capsule.
The two principal anterior muscles of the hip are the iliacus and the psoas major. Collectively, they are known as the iliopsoas muscle because they share a common insertion on the lesser trochanter of the femur. The iliacus muscle originates on the iliac crest and fossa of the pelvis. The psoas major muscle originates on the bodies of vertebrae T12 through L5 and the transverse processes of all lumbar vertebrae.
Here's a photo of the interior of the hip joint, the head of the humerus being here, and the articular capsule cut away. At the head of the femur, we see the ligamentum teres, and we get a peek at the synovial membrane as well. Around the surface is the articular labrum. Reinforcing ligaments of the hip joint or the coxal joint include the iliofemoral ligament, the pubofemoral ligament, the ischiofemoral ligament, and the ligament of the head of the femur, also known as the ligamentum teres. The slack during most hip movements that occurs in the ligamentum teres is not so important in stabilizing. The ligamentum teres does contain an artery that supplies the head of the femur. The greatest stability of the hip joint comes from the deep ball and socket joint itself. Here's the hip joint, a posterior view with the capsule in place. And here you have your iliofemoral ligament, named from where it's coming from and going to, and the ischiofemoral ligament, again naming from where it's coming from the ischium to the femur. And this would be the greater trochanter of the femur. Here's an anterior view of the right hip joint with the capsule in place. Again, the greater trochanter. Here we have the iliofemoral ligament. and the pubofemoral ligament. And there's a 360-degree view of the hip joint. Moving distally to the knee joint, the knee is the largest, most complex joint of the body. It consists of 3 joints surrounded by a single cavity. The first part is the femoropatellar joint. This is a plane joint, and it allows for the gliding motion during knee flexion. The second joint is the lateral joint, and the third is the medial joint. The lateral and medial joints together are called the tibiofemoral joint, the joint between the femur condyles and the lateral and medial menisci of the tibia. These joints are hinge joints that allow for flexion and extension and some rotation only when the knee is partially flexed. Here we have a sagittal section through the right knee joint, and we have the femur and the tibia. And here we have the suprapatellar bursa and the infrapatellar bursa and the prepatellar bursa. Within the joint we have ligaments, the anterior and posterior cruciate ligament, cruciate meaning cross, the articular capsule, and of course the synovial cavity. Superior view of the right tibia in the knee joint. This shows the menisci, the medial meniscus and the lateral meniscus, and the cruciate ligaments. We have the anterior cruciate ligament as well as the posterior cruciate ligament.
Muscles that act on the knee joint form most of the mass of the thigh and are located both anteriorly .
The joint capsule of the knee is thin and absent anteriorly. Therefore, anteriorly, the quadriceps tendon gives rise to 3 broad ligaments that run from the patella to the tibia. The medial and lateral patellar retinacula that flank the patellar ligament. Doctors tap the patellar ligament to test the knee jerk reflex. There is at least 12 bursa associated with the knee joint. And here we have an anterior view of the right knee, and we have the quadriceps, 3 of which we can see. Remember, quad means 4. We see 3. If we pull back this middle rectus femoris, we would see the 4th quadricep. They all come together through the tendon of the quadriceps femoris muscle and attach, and the patella is within that tendon, and the insertion is at the tibial tuberosity. Here we have our lateral patellar retinaculum and the fibular collateral ligament. On the medial side, we have the medial patellar retinaculum and the tibial collateral ligament, and of course the patellar ligament. The knee joint is a capsular, extracapsular, or intracapsular ligaments that act to stabilize the joint. The capsular and extracapsular ligaments help prevent hyperextension of the knee. The fibular and tibial collateral ligaments prevent rotation when the knee is extended. The oblique popliteal ligament stabilizes the posterior knee joint, and the arcuate popliteal ligament reinforces the joint capsule posteriorly. Here we have the posterior view of the joint capsule, including the ligaments, and here we see a nice view of the oblique popliteal ligament, the tibial collateral ligament, the arcuate popliteal ligament, the fibular collateral ligament, and the articular capsule. Intracapsular ligaments reside within the capsule of the joint, but outside the synovial cavity. These intracapsular ligaments help to prevent anterior and posterior displacement of the knee joint. They include the anterior cruciate ligament, or the ACL. This attaches to the anterior tibia and prevents the forward sliding of the tibia. It also stops hyperextension of the knee. The posterior cruciate ligament attaches to the posterior tibia and prevents the backward sliding of the tibia and the forward sliding of the femur. Here's an anterior view of the flexed knee showing the cruciate ligaments. The articular capsule is removed in this view, and the quadriceps tendon is cut and reflected distally. Here we have the fibular collateral ligament and the tibial collateral ligament. The posterior cruciate ligament, the intracapsular ligament, is here, and the anterior cruciate ligament crossing in front. And here's a 360-degree view of the rotating knee. Here we have a photograph of the cadaver knee, the medial femoral condyle, the anterior cruciate ligament, the medial meniscus, the lateral meniscus, and the patella is cut back. Clinically, the knee absorbs a great amount of vertical force. However, it is vulnerable to horizontal blows. Therefore, we have some common knee injuries involving the 3 C's, and those C's are the collateral ligaments, the cruciate ligaments, and the cartilages, also known as the menisci. A lateral blow to the extended knee can result in tears in the tibial collateral ligament, the medial meniscus, and the anterior cruciate ligament. Injuries that affect the ACL are common in runners who change direction and twist the ACL. Surgery is usually needed to repair these injuries. Here's the unhappy triad. This is a ruptured ACL, a ruptured tibial collateral ligament, and the torn meniscus. And you can see here's a hockey puck coming from the lateral side and nailing these 3 structures, which would require surgery to repair. Let's talk about some disorders of the joints. Common joint disorders include cartilage tears. Due to compression and shear stress, fragments may cause the joint to lock or to bind. The cartilage rarely repairs itself and needs to be repaired with arthroscopic surgery. A partial meniscus removal can render the joint less stable, but increase mobility. A complete removal of the cartilage or the meniscus can lead to osteoarthritis. Meniscal transplants are possible in younger patients. Perhaps a meniscus grown out of your own stem cells we may see in the future, and there's quite a bit of study in that direction. Here is an arthroscopic photograph of a torn meniscus. Here you have the intact meniscus, and on this section is the tear in the meniscus. Sprains are also quite common joint injuries. The reinforcing ligaments of the knee or any of the joints can be stretched or torn, and those would be named sprains. Common sites for sprains are ankles, knees, and the lumbar region of the back. Partial tears of the ligaments repair very slowly due to the poor vascularization. There's 3 options if you have a torn ligament and it's torn completely. Number 1, the ends of the ligaments can be sewn together with surgery. Number 2, the ligament can be replaced with a graft. And number 3, you can just allow time and immobilization to heal the area. Dislocations is another common joint injury, also called luxations. The bones are forced out of alignment. This is usually accompanied by sprains, inflammation, and difficulty moving the joint. The cause of dislocations can be serious falls or contact sports, and it must be treated, must be reduced to treat, meaning the dislocation, the joint must be realigned. A subluxation is a partial dislocation of a joint. Bursitis is considered an inflammatory issue with the joint, and it involves inflammation of the bursa, usually caused by a blow or friction. This is treated with rest and ice, and if severe, anti-inflammatory medications. Tendinitis is what it sounds like, inflammation of the tendon sheaths, and typically caused by overuse injuries. The symptoms and treatments are similar to those of bursitis, and many times bursitis and tendinitis occur at the same time. Arthritis. There are over 100 different types of inflammatory degenerative diseases that damage joints, considered arthritis. It is the most widespread crippling disease in the U.S. Symptoms of arthritis are pain, stiffness, and swelling of the joint. Acute forms are caused by bacteria and usually treated with antibiotics. Chronic forms of arthritis include osteoarthritis, rheumatoid arthritis, and gouty arthritis. Let's take a closer look at osteoarthritis. This is the most common type of arthritis, also known as OA. It's irreversible. It's basically the result of a degenerative wear and tear of the joint. Many osteoarthritis reflect the excessive release of enzymes that break down the articular cartilage. When the cartilage is broken down faster than it's replaced, osteoarthritis results. Bone spurs are very typical with osteoarthritis. Bone spurs are also called osteophytes and may form from thickened ends of the bone. By age 85, over half of Americans develop osteoarthritis, and it occurs more in women than in men. Osteoarthritis is usually part of the normal aging process. The joints may become stiff and make crunching noises. These noises are referred to as crepitus, and we see this usually upon rising from a seated or lying down position. The treatment of osteoarthritis is moderate activity, mild pain relievers, and different creams can be very helpful. Glucosamine, chondroitin sulfate, and nutritional supplements are also sometimes used with varying degrees of effectiveness. Rheumatoid arthritis, also known as RA, is a chronic inflammatory autoimmune disease of unknown cause. What happens in any autoimmune disease is that the immune system attacks its own cells. So this usually arises between the ages of 40 and 50 years old, but can also occur at any age. It affects 3 times as many women as it does men. Signs and symptoms of rheumatoid arthritis include joint pain and swelling, usually on both sides, anemia, osteoporosis, muscle weakness, and cardiovascular problems. Rheumatoid arthritis usually begins with the inflammation of the synovial membranes, known as synovitis or affected joint. The inflammatory blood cells migrate to the joint and release inflammatory chemicals that end up destroying the tissues. The synovial fluid accumulates and causes joint swelling. The inflamed synovial membrane thickens into an abnormal pannus tissue that clings to the articular cartilage. The pannus erodes the cartilage and scar tissue forms and connects the articulating bones, causing ankylosis. The treatment of rheumatoid arthritis includes steroidal and non-steroidal anti-inflammatory drugs to decrease the pain and inflammation. A disruption of the destruction of joints by the immune system. Immune suppressants will slow the autoimmune response, and some agents that target tumor necrosis factor to block the action of the inflammatory chemicals are promising. And this joint can be replaced with a prosthetic. Here's a picture of a hand that's been deformed by rheumatoid arthritis, or RA. Gouty arthritis comes from the deposition of uric acid crystals in the joints and soft tissue, followed by inflammation. This one is more common in men, and it typically affects the joint at the base of the great toe. If left untreated, gouty arthritis, the bones will fuse and immobilize the joint. Treatment of gouty arthritis typically include drugs, plenty of water, avoiding alcohol, and avoiding foods that are high in purines, such as liver, kidneys, and sardines. Lyme disease is caused by bacterial transmission by tick bites. Symptoms include skin rash, flu-like symptoms, and foggy thinking. Lyme disease may lead to joint pain and arthritis, and the treatment is a long course of antibiotics. Developmentally, the embryo, by week 8, the synovial joints resemble adult joints. The joint size, shape, and flexibility are modified by their use. Active joints have thicker capsules and ligaments. Advancing years take their toll on joints. Ligaments and tendons tend to shorten and weaken in advancing aging. Intervertebral discs are more likely to herniate, and most people in their 70s have some degree of osteoarthritis. Full range of motion exercise is key to postponing joint problems.